So in this particular study, just what is it you were looking at?
So in this study, what we looked at was a whole range of common health conditions like asthma and diabetes and heart disease among people who had died of overdose in British Columbia. And what we found was that these conditions were quite prevalent, but we also found it to be prevalent for people to be accessing healthcare for those conditions. So in the month before death, 1 in 3 people had actually been in contact with healthcare for their chronic disease. And so what that really suggests to us is that the context of chronic disease care, whether it be with a family physician or with a specialist, really is a place where we can look to have more open conversations about substance use and about overdose risk.
Okay. Heather, just what are some of the more common stimulants?
So when I'm referring to stimulants, I'm talking about the unregulated supply, so stimulants like cocaine and methamphetamine.
I see. Okay. And just how prevalent were they in overdose deaths?
So in our study, we found that actually 3 in 4 people had a stimulant detected in their deaths. So we know in the context of the overdose crisis, we're often really focused on opioids and even sometimes refer to this as an opioid crisis. But this study is really drawing attention to the high rates of stimulant use in the province and among people who are dying of overdose. So commonly they're co-detected with opioids, but we are seeing 3 in 4 people who are dying of overdose in the province having a stimulant detected. And really that's important because if people are using stimulants and not expecting an opioid to be contaminating that drug supply, they're really at a high risk of overdose, particularly because they won't have built up a tolerance to the opioid.
I see. So with people who have chronic conditions then, I mean, what kinds of opportunities does that present for healthcare workers to actually intervene?
Yeah, so one of the main findings that we found around chronic disease was that people with heart disease were actually twice as likely to die of a stimulant poisoning compared to an opioid poisoning. And so that suggests that it might be an important context to be having conversations about substance use and stimulant use specifically in the context of care for people with heart disease, because we're seeing this elevated risk of stimulant toxicity in that population. But then also more broadly for people who are known to be using substances, it's suggesting that we might want to consider screening them or prioritizing them for screening for heart disease.
I see. Well, and where does stigma come into the picture here? I mean, how big an issue is that when it comes to patients actually feeling comfortable reaching out, seeking help?
Yeah, you're definitely hitting on a really important point there, where we know that many people who use substances don't feel safe disclosing substance use in the context of healthcare. We've collaborated closely with people with lived experience, so people who are actively using substances who share that and say that often they don't feel safe disclosing their substance use. So I think one of sort of the messages here in broadening this to the context of chronic disease care is just thinking about opportunities to have more open conversations across the health system about substance use, particularly knowing that this drug poisoning is the leading cause of death in the province for people between the ages of 10 and 59. So we don't want these conversations to be niche. We want them to be broad ranging. And in the context of people regularly accessing care for their chronic diseases, these are places where we can start to have conversations about substance use and about overdose risk.
Well, yeah, I mean, we're having this conversation right now, and that's important. And I hope that those who are listening can pass along this information to people that they care about who may happen to be drug users as well. How do you get the message to the people that need to hear this?
Yeah, I think sort of just working across a whole range of different modes of communication to reach different audiences. So we collaborate closely, like I said, with people with lived experience, but also with physicians who are working in emergency departments and working in the context of cardiovascular disease. So, you know, having shared clinical context, conversations in clinical context, public communication, and also I think that this conversation right now is about trying to have these conversations more normalized in the context of healthcare. So if patients and clinicians can work towards having these conversations more normalized, then I think that goes a long way as well.
And you know, Heather, this conversation is timely because just yesterday we got new toxic death, the drug numbers from the BC Coroner's Service, right? They're still high. I mean, what we saw, 155 people died in October from toxic drugs. So that's, you know, an average of 5 per day. That is still the lowest monthly number in more than 4 years. So far, 2024 has had a 9% reduction in deaths from the previous year. So what do you see in those numbers, and to what level are you feeling optimistic?
I think we can be, we can try to be optimistic, but we need to continue to sort of monitor the trends over time. And of course, even if the numbers are lower than they have been, they're still unacceptably high, and we're still in this public health emergency. So absolutely, we need to continue to monitor the data and see what happens over time to see if these trends sort of continue.
Okay, so you're not getting into that optimistic mode just yet.
Exactly.
I hear you. Heather, really a pleasure to hear from you this afternoon. Thank you very much.
Thank you very much for having me.
That's Heather Palis, Senior Scientist for Harm Reduction at the BC Centre for Disease Control.